Hello, everyone. Thank you very much for your interest in this presentation, and thank you, NutriBest, for the invitation. So today I'm going to talk a little bit about how to define and differentiate different conditions that are related to low muscle mass. We're going to talk a little bit about sarcopenia, malnutrition, frailty, and cachexia. So there's a lot of confusion in the literature regarding this condition. Sometimes we use the terms interchangeably, but these are certainly different conditions. We have been hearing more and more about these conditions. Many clinical guidelines now really emphasize the importance of low muscle mass, whether it's in the context of one of these conditions or low muscle mass in isolation. So this is why really we have seen a lot of this focus on muscle nowadays because the literature is emerging, a number of different tools and approaches to assess body composition techniques, anthropometric or surrogate anthropometric markers have really highlighted the prevalence and the importance of low muscle mass, whether again alone or in the context of each of these conditions. So I'm going to talk a little bit about low muscle mass in the context of sarcopenia, malnutrition, frailty, and cachexia. So as I've mentioned perhaps twice now, a low muscle mass can occur alone. So it's not only occurring in the context of sarcopenia or the other conditions. And sometimes this is a bit of a different concept for us because we have seen the term sarcopenia in the literature so often. And as you can see here in this figure, sarcopenia is a term that has been actually originally used to describe the loss of muscle mass and strength that occurs with aging. So the term sarcopenia and most of the sarcopenia definitions nowadays acknowledge that yes, low muscle mass is important, but low muscle function is also assessed. And that could be through low muscle strength or poor physical performance. Now, we have used the term sarcopenia interchangeably in the literature to refer just to low muscle mass, especially in the context of chronic conditions such as cancer, for example. And because this term sarcopenia has been used just when people are, or researchers are measuring low muscle mass, um, there has been proposed that there are different contexts of sarcopenia. And the terminology that was used was primary and secondary sarcopenia. Primary sarcopenia being the sarcopenia associated with the aging process, and secondary sarcopenia being the sarcopenia associated with chronic conditions, so not necessarily related to aging. So, because of that, again, this term has been used interchangeably in the literature, in the cancer literature. Most of the papers that mention sarcopenia have actually only measured low muscle mass, not necessarily low muscle function. And I have published before calling low muscle mass as sarcopenia, but I don't do that anymore. And I'm not saying that's incorrect, but what I believe we can do is fine-tune terminology or maybe strategize terminology better so that these conditions are understood as separately. And we discussed that in this paper, and this is an open access paper, so I invite you to read our discussion. And we talk about how sarcopenia is different than low muscle mass. And perhaps now it's time for us to differentiate these conditions. First of all, before you even look at the figure, there is a lot of confusion because you see, for example, a number of papers where people are assessing sarcopenia. And when you look at the population, they're assessing sarcopenia using the definitions of sarcopenia in aging, but their population include younger individuals. So they can be using screening tools like the SARC-EF questionnaire. That's really not appropriate for younger individuals because, again, there is this confusion in the literature. So now looking at the figure here, you can see that we have on one side, the discussion of sarcopenia, the other side, the discussion of low muscle mass. And when we consider sarcopenia, again, sarcopenia is a term that was originally used to describe this aging process. So it's used to define this complex geriatric syndrome. And this geriatric syndrome is associated with muscle as a functional organ. Therefore, the outcomes are associated with this with sarcopenia are functional outcomes. So they're associated with mobility impairment, falls, for example. And this is different than when we observe low muscle mass. So low muscle mass is a concept or can be present in people of any age. So that alone is important for us because when we use the term sarcopenia, perhaps many healthcare professionals who are not aware of what we're discussing here today only understand the sarcopenia to be a problem for older adults. So when we use the term low muscle mass, perhaps we can really differentiate and show that even children can have low muscle mass because this low muscle mass is not necessarily associated with aging. It's associated with acute and chronic disease and can or cannot occur in the context of low protein and energy intake. But the point here is to say that it's in the context of acute or chronic disease. So now we have impairments that are related to muscle as a metabolic organ, as a systemic organ that is responsible for the production of myokines that are going to be leading or intermediating this crosstalk among organs. It's responsible for the reservoir of amino acids in the body that are mobilized in times of need, such as in the context of these acute and chronic conditions. It's responsible for glucose metabolism. So again, muscle as a metabolic organ. Therefore, when we see individuals who have low muscle mass, the consequences of that are related to clinical outcomes. So they're associated to need of hospitalization, length of hospital stay, mortality, for example, among other clinical outcomes. So these conditions are different, and I think that that's important for us to understand that. Now, the term sarcopenia has also been used in the context of sarcopenic obesity. And I leave you with our paper here, Nonini et al., that discusses the new proposed diagnostic criteria for sarcopenic obesity. And we discussed that in our paper that this diagnostic criteria is pretty much considering the aging process, although we're telling people that, yes, you can use this in different contexts because we really need more research to understand that. But in the context of obesity, sarcopenia can also exist. And here, when you look at our diagnostic criteria for sarcopenic obesity, we're looking at both altered skeletal muscle function and altered body composition. And with altered body composition, we have increased fat mass and reduced muscle mass. So the diagnosis is the second step on this process. The first step would be screening, as you can see here. And again, we have to understand the clinical population that we're studying. If we're using the SARC-IAF questionnaire, you're going to be using that in older adults only, or using in younger adults, but again, understanding its limitations, or even better, using it in the together with calf circumference, which is not the topic or the purpose of my or the topic of my presentation today, but very interesting and relevant. You can certainly let us know if you want to learn a little bit more about that. And then after the diagnostic criteria, the next step would be staging. And with staging, we have stage 1, which is no complications, and stage 2, where we have at least one complication attributable to sarcopenic obesity. So the next here in our list is malnutrition. There are many definitions of malnutrition, but certainly the most important one nowadays, important saying, because there is an international consensus, is the GLEAM malnutrition criteria. And GLEAM stands for Global Leadership Initiative on Malnutrition. So with GLEAM, we have different ways, not a different way, but it's more a systematic way of looking at malnutrition, as I'm going to show in the next figure here. So this is the GLEAM approach to diagnosis of malnutrition. And again, the point that I want to highlight here is in GLEAM, which is very positive nowadays, is the focus on muscle mass or muscle mass assessment. So this figure is showing us the steps towards applying the GLEAM diagnostic criteria. And I'm going to get to the focus on muscle mass assessment next. And here all we have in each of these quadrants, 1, 2, 3, and 4 are the steps. So GLEAM criteria, you would start with using any nutritional risk screening tool, any validated tool, and then you would check the 5 GLEAM criterias against any tool that you're currently using for the diagnosis of malnutrition. So GLEAM is not asking us to replace what we're currently using. It's actually saying, okay, you can continue to use the tool, just use that information to apply that within the GLEAM context or the GLEAM criteria. And finally, here we have the GLEAM criteria. And as you can see here, reduced muscle mass is one of the phenotypic criteria. So for a person to have a positive malnutrition diagnosis using GLEAM, this person would have to have one of these positive phenotypic criteria together with a positive etiologic criteria. So either they have to have weight loss, low BMI, or reduced muscle mass, plus reduced food intake or assimilation and inflammation or disease burden. So one of the advantages of using GLEAM criteria is that it becomes much easier for us to identify reduced muscle mass in people with obesity, because we know that certainly they wouldn't meet this criteria of low BMI, and that weight loss can also mask body composition changes. In fact, we have published a study showing that people can have weight stability, but be substantially losing muscle mass. So GLEAM is very positive, and it's a step forward in terms of diagnosing malnutrition in people with obesity. And the last step in this criteria would be grading the severity, whether it's moderate or severe malnutrition. Now, next we have frailty, and frailty is already getting, in the context of a more serious condition. Now we have low muscle mass in the context of weakness, low walking speed, and balance impairment. And frailty is really a multidimensional problem. We have biological determinants of frailty, psychological determinants, social determinants, and frailty determinants itself. So frailty is really a combination of a number of deficits. So it's a cumulative deficit model that eventually will lead to this vulnerability and to frailty. So we have impairments in mobility, cognition, mood, social vulnerability, certainly comorbidities, nutrition, including low muscle mass, energy, so exhaustion and tiredness, as well as functional problems. So eventually, all of this will lead to this deficit or substantial deficit model of vulnerability that will lead to frailty. So it's really a worse, not the worst, but a worst case compared to the previous conditions related to low muscle mass that we have studied before. And finally, we have cachexia, and certainly cachexia is the worst case scenario where you have substantial weight loss, low BMI, low muscle mass, and that's in the context of a severe condition, usually chronic condition. And this is an example of a definition of cachexia. This slide is in the context of cancer cachexia. There are several different types of cachexia. And this is a commonly used and accepted definition of cancer cachexia. It's a continuum that can start with pre-cachexia, and then we have cachexia as well as refractory cachexia. And if you look in the middle here, we have the definition of cachexia. And relevant to what we're discussing today, we have low muscle mass, which they've called sarcopenia in this context. But if you read the paper at that time, 2011, that was the term that we were using in the oncology scenario. So this certainly relates to low muscle mass. But obviously, these patients also have low muscle strength, because again, it's a very severe condition. You can see here the different ways of defining cachexia. We have weight loss greater than 5%, or BMI less than 20 and weight loss greater than 2%, or sarcopenia, or low muscle mass, and weight loss greater than 2%. And this obviously is often happening with reduced food intake and systemic inflammation that's occurring due to the highly catabolic disease. So again, one example, and highlighting again that low muscle mass is also important and one of the defining characteristics of cachexia, in this case, in the cancer context. So hopefully you've enjoyed this presentation. It's very brief discussion on some of these conditions, but certainly there is a lot of entanglement in the literature, a lot of things that we have to try to understand better. Certainly, I think this is an evolving knowledge. I may come back next year with a totally different definition of some of these syndromes, who knows? But I would just like to thank you very much for your attention and see you next time.